Thanks, everyone. Good morning. So I have no disclosures. So just the outline will be just to review the surgical outcomes for patients treated with neoadjuvant Nievolumab and try to give an update on the recent oncologic follow-up of the cohort that we're following at Johns Hopkins and Sloan Kettering. And then also to present some correlative science and then just look at how these agents might be used in the future. I think the important thing with this project was just the collaboration. So it's a collaboration across two institutions, our institution at Johns Hopkins, and then our collaboration with Memorial Sloan Kettering, and then two disciplines, thoracic surgery and medical oncology. And we're so used to, oftentimes we do surgery and then we send them off, or if we see somebody with advanced disease, we send them off. But this was really a collaboration where, in order to recruit patients, to make sure that they got their medicine, the immunotherapy in a seamless manner, and then were put on study, and we didn't have any protocol violations for some of the important endpoints, as you'll see. And then I want just to introduce you, I guess, in a sense, to these four young investigators who are really the backbone of how this all came to be. And so Patrick Ford is a medical oncologist who was a principal investigator on this trial and really kept us as surgeons on task to make sure that we weren't having people come to our clinic that were eligible for their trial and that wasn't discussed, and that's a lot of work when we have busy clinics. He also made sure that he individually saw every patient before they were put on trial to make sure they're eligible. Elsa Anagasto is a young medical oncologist who is doing all of the correlative science to really get a better understanding of how these work or which patients are going to respond and which patients aren't. And then on the surgical side, Stephen Broderick in our group and Matthew Bott from the Memorial Sloan Kettering group actually did a lot of work to really understand about the surgery. And I'm going to start with the surgery first. So this is the presentation from the ATS, so you'll recognize the slides, looking at the operative experience. And so basically, we knew that immune checkpoint inhibitors had been an important part. We used Nievolumab in the study, but also others have been used and demonstrated in metastatic disease to work quite well. And then Pembro, everybody calls it, has really been pushed even after chemo-rads for patients and in other areas. And now the last group of patients, I guess, is going to be the patients who are getting double immunotherapy, so a combination of Nivolumab and Ipilimumab have been used. And so trying to understand these medicines, how they work, and of course, one of the biggest side effects is pneumonitis. So we as surgeons were a little bit concerned that if the patients got these immunomodulatory agents and then got post-resection acute respiratory distress or failure, all of a sudden we're switching the morbidity after surgical resection on us, and that was something we had to work through. So there were a lot of talks about what kind of PFTs would make patients eligible for the study, and that all had to be worked out before it was open. Again, the rationale for applying it to patients who are normally resectable, who would be taken most times to the operating room, was just that we really hadn't pushed the needle when it came to 5-year survival for patients with lung cancer. And then the enthusiasm for these PD-L1 agents had really increased. And then there's this really scientific part that we wanted to answer too, and that is that if you give it in the situation in which it's been pre-treatment, you've got a higher antigen load for presentation, the real question for long-term immunopriming. And then the other thing would be is if we're trying to figure out how these very, very expensive agents work, it's going to be critical to know who we should be giving them to. So when they work, great, it's amazing. But when you're giving $70,000 medicines to people who don't respond, that starts to get expensive for our healthcare system. So this is the schema. So newly diagnosed resectable stage 1. It had to be greater than 2 centimeters through 3A. They got 3 milligrams per kilogram IV of Nivolumab, basically 28 days before the scheduled date for surgery, and then again at 14 days. In all of the studies, day 0 is on the surgery date. And then post-operative, we gave the standard care. The primary endpoints were really safety and feasibility. Again, this issue with pneumonitis or other potential surgical morbidity. We wanted to know if it would delay resection, especially for patients who normally would go right to surgery. And then the exploratory endpoints are basically pathologic response. And a major pathologic response was less than 10% residual viable tumor. And then, of course, the immunologic and genomic correlates. So a total of 22 were enrolled, but one was withdrawn there because upon path review, they really had small cell. But of the 21 patients with non-small cell lung cancer that were treated with preoperative intent, 20 underwent resection, and the one unresectable one had tracheal invasion that was identified at bronchoscopy. So it wasn't sort of an open and close, it was more found by bronchoscopy. Patient characteristics are pretty much what we're seeing in our practice. Pretty much a male to female equivalence. Adenocarcinoma was primary histology, and most were former smokers. I think just to think about as we move forward with clinical trials in the future, it was interesting that we were able to actually recruit 4 patients who had clinical stage 1 or 1B, 1A or 1B tumors. These are patients that really in the usual paradigm would have surgery and be done. The patients that we recruited were just very motivated patients to participate. They had read about immunotherapy and they just want to be a part of this trial, which actually surprised us. I will say that many other patients said, geez, if all I need is surgery, why am I going to do anything else? And so you have to have that conversation. But for the patients with 2A, 2B, and 3A disease, it actually is easy to sell the patients on this trial because I told them, look, if we do your surgery, you're going to be followed up with chemo. If you've got stage 3A disease, you're going to have chemo first, surgery, or chemo radiation first and surgery. So here's an opportunity to take this treatment that's novel up front. And it wouldn't burn any bridges. So a lot of people with this signed on, and we had more patients, I think, who were not eligible to participate than we had people that didn't take the therapy. So I think that's optimistic, hopefully, as we move forward with these kind of trials. So the first thing is when you look at radiographic response, it's nothing you can count on. You can see that 2 patients had a partial response, most had stable disease, and 1 actually had radiographic progression. And this is the 1 patient with radiographic progression. You can see that on the top, the mass actually went from the top to the bottom as growing in size. And this is one of the patients who had a major pathologic response that had less than 5% tumor. So one of the things we learned pretty quickly was RECIST criteria and radiographic response is irrelevant when you're looking at these patients. Now, when you look at the surgery aspect of things, 20 ultimately underwent resection. 7 went right to thoracotomy. It was the surgeon's decision. They were just going to do a thoracotomy. Of the 13 that were started minimally invasively, either by VATS or robotic, half of those, 6 were completed by VATS, and 7 were converted to thoracotomy. And Matt and Stephen Broderick looked really carefully at the indications for conversion. Perihilar fibrosis was probably the most common injury to the bronchus intermedius just during a difficult dissection, which was repaired, and then bleeding. And 1 patient lost 1,000 mils of blood and did not need a transfusion, but in an immunotherapy trial, when all of us know that the negative oncologic consequences of giving a patient blood transfusion, everybody was pretty set on not having that happen to them. So I think that the conversion to thoracotomy is just going to be a real phenomenon in these patients. If you look at the extended resections, what you'd expect with this population, 80% underwent a lobectomy, 2 needed pneumonectomy, bilobectomy of 1 and sleeve 1, and only 1 patient underwent a wedge. And you can see the perioperative alkyne surgical time, estimated blood loss, length of stay. We had 90-day mortality, which is great, and atrial arrhythmia with our major morbidity. So again, patients came through the surgery quite well without any undue side effects. So 9 of 20, so 45% of the patients had a major pathologic response, is again defined by 10% residual viable tumor. Pathologic downstaging, which is always very difficult to do accurately, but the consensus when Stephen and Matt went through things, there was 8 of the 20 had pathologic downstaging. And then there were 2 complete pathologic responses. So I think the first section here were conclusions. Well, we could use these immunomodulatory agents, at least 1 agent at a time, Nievolumab in this case. The outcomes were similar to other patients with neoadjuvant chemotherapy followed by pulmonary resection in regard to operative morbidity. We did see maybe an unexpected increase in the conversion to thoracotomy. And again, on a prospective randomized trial, I think surgeons involved don't want those patients to have any of the least chances. So I think all of us involved probably felt like we wanted to make sure these patients came through smoothly. We're very happy or kind of relieved that the pathologic response was 45% had a major pathologic response. So that means that these agents appear to be working. Because if you look at the blot trial, which was the only other trial that we really looked at, the complete pathologic response was only 5 or 6%, and nothing came anywhere close to a major pathologic response. And I think we're really going to have to then decide the ongoing trials, if there are any advantages or disadvantages of this treatment paradigm, and that's still up in the air, although I'll show one trial a little bit later about that. So what about long term? So, this trial was closed, and Matt and Stephen presented the data, but as of January 24th of this year, the median follow-up of 30 months, the relapse-free survival and the overall survival, the median has not been reached. So that's encouraging. So it wasn't like we're just sort of pushing things out 90 days, but actually this benefit seemed to be longer term. There has been relapse of 5 patients and 2 deaths. One was a traumatic death that was not related to lung cancer at all, but one was due to lung cancer. Of the 9 patients with a major pathologic response, 1 has recurred, but this was definitively treated with chemorads at 13th month and now is disease-free. And there's only been 1 late, like grade 3 immune-related adverse event, and it was dermatologic. So again, we look at people under the radar for that first 90 days, but even longer term, we're not seeing any untoward side effects. So here's the Kaplan-Meier survival for relapse-free survival. The confidence intervals around it, but you can see at 12 months it's 80%, and at 24 months it's 69%. So again, pretty encouraging, at least with this small cohort. These are the 5 patients that recurred. Again, the pretreatment stage was 3A, and that's what you'd hope for, that it wouldn't be the stage 2s or stage 1s. And the important thing is that the only been 1 death, and that was the top bar there. Everybody else has been, 1 with brain metastases, had resection and brain radiation, has done well. The other patient who had a complete pathologic response got definitive chemorads, and he's still doing well. We do have 1 patient lost to follow-up, which is always disconcerting because when you have a small cohort, 1 of 20 is important, so hopefully that patient can be rediscovered. The other thing about it is that there wasn't a rhyme or reason, so you can see that of the patients, the pretreatment PD-L1 was unexpressed in 3 patients, but highly expressed in 2 that recurred. Some patients had no residual tumor or low, like the 1 patient that recurred had 5% residual tumor, but still recurred. So I think one of the issues is we're not really sure how these agents work quite yet, and that's really important for the correlative sciences. When we look at the correlative sciences, you can see a real relationship between the tumor mutational burden and the pathologic response, and that's been also held up in other studies. So a lot of patients that have these testing are now looking at tumor mutational burden. And they've also demonstrated, I don't have the pointer here, but you can, oh, black one, sorry about that. I just want to show you that when a couple patients, I think it's up to 12 of the 20 patients have had the correlative sciences done on it. But you can see this is the correlation between tumor mutational burden and pathologic response. But this is interesting here. The patients have, these are the Tcell clones that they're following closely. So at time 0, they have very few clones. This is the first dose of nivolumab. By the second dose of nivolumab, they're up. And then basically they start to drift down. But the importance of this is they can find the frequency of these clones out in the resected tissues as well as in the bloodstream. And if you look at a couple patients here, you can see these patients with pathologic response. You can also correlate with tumor circulating DNA. So they had tumor circulating DNA at the time when they got their treatments. And if they stay with tumor circulating DNA levels that are quite low, these are just 2 patients, that also correlates quite well with on-turning, no evidence of radiographic disease. So ELSA is really working to try to identify these biomarkers in real time to make sure we're not just following patients who might need other therapies. The other question would be is will we see changes in these profiles before we see radiographic recurrence, and how will we work with that? So I think these correlative sciences are very important, especially because of the expense of these medicines. This also shows that in patients who have a good response to the treatment, they get expansion of their Tcell clones. And we're hoping, that would be the hypothesis that expansion of the Tcell clones is going to be associated with relapse-free survival. And again, just another one, just these clones go up with the treatments. You can see they were low, they go up, and then they stay high out long term. So now this is the Natomas study. It was presented at the World Conference of Lung Cancer last year. And what you can see, the schema, these were all 3A patients. The dose of nivolumab is significantly higher, I assume, because they give, I think it's 360 milligrams of nivolumab. We were given 3 milligrams per kilogram, so you figure a 70 kilogram person is going to be getting 200 milligrams, so that's a pretty high dose of nivolumab with paclitaxel and carboplatin. Then they had their surgery, and they also got adjuvant nivolumab only as the kind of the maintenance arm or the consolidation arm, and then follow-up. And you can see that in this group, it's on 30 patients, but 80% had a major response, and 75% had a complete pathologic response out of 30. So this is encouraging that it can be used safely in combination chemotherapy in 3A disease. And so I haven't seen that paper been published with all the details, but I think that's coming up. So again, they can be safely combined with other agents, which is going to be important in our 3A patients, because right now there's probably as many opinions in this room as there are ways we treat 3A disease. Chemo-rads first, followed by surgery, chemo, followed by surgery, and then see what the path shows. Now, using agents like this may make a lot of sense. So just in conclusion, there's been minimal long-term related adverse events following use of these agents, so that support the safety and feasibility in using them even in resection, pre-resection. The early relapse-free survival has been pretty encouraging, but things, the questions remain between correlation survival, pathologic response, risk factors, and things like that we have to work through. I think this circulating tumor DNA, being able to follow that closely is going to be important. Again, when we're using expensive medicines, we have to really be sure that we're giving the right medicine to the right patient. This idea, the hypothesis that generating a true anti-tumor response is correlating with long-term survival, that's important. And then, again, the initial reports of combination therapy with standard chemotherapy is also promising. So, thanks.